Good morning, all. Thank you for attending. As Jared said, welcome to the first MDT for the year. It somehow makes me think of surf and turf. I don't know, renal and rheumatology. I have a weird mind. Um, our colleagues, Dr. Rajoo, who has completed her exams and is, I guess you could say, really close to being a nephrologist, like really close. Okay. Just to introduce, she will lead off. Dr. Balton, who's a senior in the division of rheumatology, will do the second part. The talk this morning is on probably one of the most devastating and frustrating diseases to treat for both actually the doctor and very much so the patient. So thank you for your attention. We hope you enjoy the talk.
Good morning. So we're going to discuss scleroderma renal crisis. This talk was inspired by one of our patients from a couple of years ago at the unit, I think about 4 years ago. She was then 46 years old, was referred to the ED from the local clinic. She was known with a background history of HIV, which was well controlled on ART, and was already known to rheumatology with diffuse systemic sclerosis. At the time she presented, she had been on chloroquine and Cellcept for the past 3 months, but she had just completed 6 cycles of cyclophosphamide 3 months prior. We didn't quite know the indication at the time, but after taking a thorough history and discussing with rheumatology, it seemed that she had gotten the cyclophosphamide for rapidly progressive skin thickening, which is quite relevant because that is a known risk factor or an important risk factor for scleroderma renal crisis. So on this occasion, she presented with a history of vomiting, quite severe. She vomited about 4 times, which necessitated her coming to the hospital. Clinically, we noted that she had contractures from the scleroderma. Of note, they were around her elbows, which is a large joint, which is also another risk factor for developing scleroderma renal crisis. She had other typical features one would expect with systemic sclerosis, as well as suspected esophageal disease based on a history of dysphagia. She had a blood pressure of 168/98 at the clinic, and this continued to rise later on that day with systolics reaching 220 and diastolics of 110. She was oliguric at the time of transfer from the local clinic, and she ended up becoming anuric a few days later. On admission at the ED, her urea was 12.8, her creatinine was 179, her platelets were low, 113. Unfortunately, we didn't have a smear at this time. That would have been useful because we would have wanted to look for features of a microangiopathic hemolytic anemia. But she did have a normal renal function from the rheumatology clinic about 3 months prior, so this looked like a true acute kidney injury. She also had an elevated urine PCR at this time. Obviously, with the high blood pressures, it may reflect a slightly inaccurate estimate, but it was subnephrotic, and that's important because to get nephrotic range proteinuria in a patient with scleroderma, one would have to entertain other possibilities besides scleroderma renal crisis, but we'll discuss that shortly. So what ended up happening with our patient is about 4 days later, she ended up becoming dialysis requiring. She had progressively declining kidney function, eventually became anuric, went into pulmonary edema, and we had to start dialysis. When we started dialysis, there were some considerations at the time. One was to hold her immunosuppression because she developed a sepsis and was started on tazocin for that. But she also, there was consideration to start an ACE inhibitor. There was a bit of hesitancy starting an ACE inhibitor on admission when she first presented because she had a bit of renal function. She was passing some small volumes of urine. She presented with a severe AKI, and there's a little bit of traction starting an ACE inhibitor in those kind of patients. So it took us quite some time, I would say about 2 weeks before we became brave and we decided we needed to start the ACE inhibitor because the most likely diagnosis was scleroderma renal crisis. We also decided to repeat her autoimmune serology at this time because of the rapidity of the acute kidney injury. It's important to exclude other conditions that could overlap with scleroderma or other causes of an RPGN like ANCA. And we performed an ANCA, which was negative. We did the anti-GBM serology, which was also negative, and a double-stranded DNA, which was also negative. And part of her antibody profile included an RNA polymerase 3 antibody, which happened to be positive, and we will discuss that further shortly. There was also consideration from the renal team to do a kidney biopsy at this time. It's not necessary to do a kidney biopsy for all patients with scleroderma or suspected of scleroderma renal crisis if they present typically. But in her case, she did have significant degree of proteinuria, number one. Number two, this was a rapid onset. We wanted to exclude other pathology like a TMA. And the other concern was she was now on dialysis for 2 weeks with no signs of opening up. We wanted to know her degree of sclerosis and potentially irreversible renal damage. Okay, so this is some histology pictures taken from the internet from an open source. I didn't have images from her biopsy, but I would imagine hers wouldn't look too different from this. So on the left-hand side, we have a PAS stain, and the arrow is pointing to a small vessel. And as you can see, the vessel is completely occluded. It's obliterated because you have intimal hyperplasia. And this is a typical feature, though not pathognomonic, of scleroderma renal crisis. At the center of that image, you'll see a glomerulus. It looks quite shrunken and shriveled. This is what we call like a wrinkled basement membrane. It's basically an ischemic glomerulus, okay? And that's what scleroderma is doing to the kidney. It's renal vasospasm, or the so-called renal Raynaud's, and it's depriving your glomerulus of blood. On the right-hand side, this is a silver stain. So silver stain will stain the collagen, and you can see it's staining quite nicely this vessel. So it's fibrosed. So her biopsy showed 70% of the glomeruli looked like those glomeruli. They were wrinkled. 2 of them showed features of thrombotic microangiopathy, which is not completely unusual or unexpected in a patient with severe scleroderma renal crisis. And she had what the right-hand picture showed was onion skinning of those blood vessels, which will eventually cause luminal narrowing and deprive your glomerulus of blood. Okay. So my part of the talk, we're going to briefly discuss the risk factors of developing scleroderma renal crisis so you know which patients to suspect this condition on, the pathophysiology of it, and that will inform how we manage the scleroderma renal crisis. Okay, so briefly, renal disease in scleroderma is not limited to just scleroderma renal crisis. That's obviously the most feared complication, but autopsy studies have shown that up to 60% of scleroderma patients, so this includes limited and diffuse diseases, have about some degree of renal involvement. And this can range clinically from mild proteinuria because of the renal vasculopathy to elevated creatinines, which need to be monitored closely, as well as isolated hypertension. Often these patients are getting concomitant nephrotoxins. They may be taking non-steroidals not prescribed by us per se, but getting it for other reasons such as joint pains, as well as getting cyclosporin or tacrolimus for their other autoimmune pathologies. And like I mentioned earlier, they may also present with overlap syndrome, so other autoimmune conditions like lupus and rarely ANCA, as well as TTP. Okay. So with regards to scleroderma renal crisis specifically, it was first described by a dermatologist in Austria in 1863. He described the death of a patient, a young person, with thickened skin and uremic symptoms. But the histology was only first discovered in the 1930s. Okay, so what we know right now is that scleroderma renal crisis has a prevalence overall of about 10%. It has a predilection for those with diffuse disease, affecting up to 20%, but it rarely can occur also in those with limited disease. We are seeing a decreasing incidence of scleroderma renal crisis currently, and this may be due to a variety of factors, one including a wider spread use of vasodilator therapy for other manifestations of scleroderma, such as Raynaud's or pulmonary artery hypertension, as well as now a more judicious steroid and cyclosporin use because we know the patients who are at risk of developing this crisis. And amongst our population, the African population, we may find a lower prevalence of RNA polymerase III, which is a known risk factor for developing it. Of note, like I said, it's more common to be found in those with diffuse scleroderma, even more so in those with early disease, so within the first 5 years of presenting with their scleroderma. The median time to diagnosis is usually within 8 months. Okay, in the pre-ACE inhibitor era, so pre-1980s, this condition carried a very poor prognosis. Most patients died within the first year of developing it, with a 10% survival rate. Since the introduction and more widespread use of ACE inhibitors to treat it, survival has improved to 85%, but it still has a lot of morbidity, which we'll talk about. So the risk factors. So after decades-long studies, they've identified those patients who have the typical clinical risk phenotypes, and these are the patients we need to be aware of to be aware of developing this condition. So like I said, early on in those with diffuse systemic sclerosis and those with rapidly progressive skin involvement, which is suggested by our patient's history, going in with this diffuse skin involvement, they may also find tendon friction rubs. And I mentioned the RNA polymerase III antibody positivity. With regard to a drug history, steroids, particularly high-dose steroids, which are defined at about 15 milligrams a day, increase the risk of developing this condition. And there's multiple reasons for this. We know that steroids increase the risk of hypertension because of their ability to enhance water and sodium retention, as well as their ability to induce angiotensin-converting enzyme activity. But they also increase endothelin expression in the kidneys, and that's a potent vasoconstrictor. And then I put calcineurin inhibitors as a potential cause because calcineurin inhibitors tend to increase blood pressure. They also increase sodium and water retention in the distal tubule, so that may precipitate a hypertensive crisis. And there is a genetic link, as you can see below. Okay, so briefly the pathophysiology. So on the left is a very simplified diagram of the pathophysiology, but essentially, like I mentioned, scleroderma it's a systemic vasculopathy and the renal vessels are not spared. So a patient with scleroderma who's at risk will have a background renal vasculopathy, interstitial fibrosis, and an inflammatory immune dysfunction already. Then there's some sort of inciting event, which may be a vascular event or steroids, for example, which will precipitate a crisis, and it increases blood pressure, causing endothelial damage and injury and activating these endothelial cells. The endothelial cells will then express endothelin-1, as well as there may be the presence of other autoantibodies to endothelial receptors like endothelial A and angiotensin-1 receptors that are expressed on the surface of the endothelium. All of these will then activate the endothelium, which will also, one, drive expression of transforming growth factor, which will enhance fibrosis, as well as lead to intimal proliferation. So you'll get the mucoid intimal edema and the onion skinning, which I showed you earlier. And this will lead to the narrowed, occluded interlobular arteries, which just feed the glomerulus and lead to glomerular ischemia. So as a result of glomerular ischemia, your juxtaglomerular apparatus will then read this as ischemia and hypertrophy, secreting more renin, and this will precipitate this hypertensive crisis with unregulated renin activation. And then you'll get your pictures of malignant hypertension and acute progressive kidney failure. And like I mentioned earlier, quite a few of these cases can be associated with the thrombotic microangiopathy. So how do they present? So typically, they would present with abrupt onset hypertension, and this is defined as above 140/90. But importantly, not all patients may manifest typical hypertension. It may just be higher from their baseline blood pressure. So that's important to note what their baseline blood pressures are and whether it's just slightly higher than their baseline. A subset of them may be normotensive, and this bears a poorer prognosis for multiple reasons, probably because it's not suspected when you see these patients that they're actually having a scleroderma renal crisis, and also that they may not tolerate larger doses of ACE inhibitors when we come to treat them. The other part of the presentation is an acute kidney injury, which is defined by the KDIGO definition. So it's rapidly progressive, and they may go on to develop anuria, like in our patient. And then with this picture of malignant hypertension, you may find other features of a malignant hypertension, such as the retinopathy and hemorrhages, as well as encephalopathy and the features of a TMA and a MAHA. Importantly, do the dipsticks because you should expect bland urinary sediment. You might find some mild degree of proteinuria and a mild degree of hematuria, but nothing more than that because it's a vasculopathy. It's not a glomerular nephritis. Should you find active urinary sediment, you need to consider other overlapping etiologies. This is a classification criteria from the Scleroderma Clinical Trials Consortium. It basically discusses the same parameters that I just mentioned. It's used mostly for trial purposes, but if you want to know the specific definitions that they use for defining hypertension, it's on here. So briefly into the management, if you haven't guessed it already, it's going to be ACE inhibitors, which are the first line agent, okay? So prior to the advent of ACE inhibitors, this crisis was poorly managed with agents like methyl-dopa, propranolol, and then dialysis when they became dialysis requiring, and even bilateral nephrectomy to control this blood pressure. Now with ACE inhibitors, they still remain the first line agent, and nothing that's come after it has been as beneficial to mortality and renal prognosis as far as ACE inhibitors have been. So initially you would target a drop of about 20 millimeters of mercury over the first 24 hours, trying to achieve normal tension by 3 days. But it's important to continue this drug even if the creatinine rises, even if the potassium rises, even if the patient becomes anuric, because then you can dialyze the patient, and you continue this drug even on dialysis. If you can't control the blood pressures with other agents, then you would add other agents like calcium channel blockers and nitrates if very severe. Avoid diuretics because of the potential to increase RAS activation unless your patient is fluid overloaded, and avoid beta blockers because beta blockers can further worsen the renal vasospasm. Okay, half of our patients who present with the renal crisis may end up requiring dialysis. And then, like I said, a subset of them may present with the TMA, and if severe, treatment is difficult because it's not necessarily related to a deficiency of ADAMTS13 like you would expect with the TTP, but there have been some case reports of a mild beneficial effect of therapeutic plasma exchange. This is possibly because of the role of the alternate pathway complement involved in the pathophysiology. In terms of prevention, it's really not preventable. You have to identify the at-risk patients and keep a very close eye on their blood pressures. Avoid adding those drugs that I've mentioned that can potentially precipitate this crisis, and avoid prophylactic ACE inhibitors. And this is because you can mask the early onset of the rise in blood pressure and delay treatment. And often the doses that we start them on with ACE inhibitors are not enough to block the RAS system completely. Okay, so this is a nice sort of flow chart on how to manage it. It's very similar to how you'd manage other hypertensive emergencies, but obviously with the first line agent here being an ACE inhibitor and avoiding beta blockers if possible. Okay, this is taken from the UK Scleroderma Society. In terms of novel management, like I mentioned earlier, nothing's really been as beneficial as an ACE inhibitor. So you would think, given the pathophysiology, that endothelin receptor blockers would be useful, especially since we know that they have elevated levels of endothelin-1 as well as expression of endothelin-A receptors. But small trials, these were small trials that used bosentan and small case series. They didn't really show any improved outcomes, so there's still further study needed on that. But it doesn't look promising at the moment. In terms of complement inhibition, for us at the moment, it's not relevant. We don't have it available. But there have been some case reports, particularly with those with TMAs as well. On biopsy, there's evidence of complement activation with C5b deposition. So using a C5 inhibitor like eculizumab makes sense. There's been some reported benefit. At the moment, it's only recommended for those who don't respond to an ACE inhibitor and don't respond to plasma exchange as an add-on therapy. In terms of the prognosis, so the 1-year survival has improved to about 85%, previously where most patients died within the first year, and this is because of the ACE inhibitor. 50% of patients will require dialysis, and half of them may recover, but recovery takes long. They can recover from anywhere from 3 months up to 2 years. So for that reason, delay transplant in these patients because they still may recover. The poor prognosticators include delayed blood pressure control and normotensive scleroderma renal crisis, older age, probably because they have poor renal reserve, as well as a very elevated baseline creatinine. And then there are some biopsy features such as the extent of the vascular injury and extent of the glomerular collapse, as well as evidence of complement activation. So back to our case, she was discharged just after a month after admission. On a discharge summary, she was back onto renal-friendly ARBs, chloroquine, amlodipine, and a PPI. But for some reason, an ACE inhibitor was not scripted. I think this was an oversight. I'm assuming it was scripted when she was back at the dialysis unit because unfortunately, she was dialysis requiring for the next 2 years after that. But this is her at the clinic a month ago. Prof. Paget saw her, and She's coming to our ROPP clinic. Her last creatinine was 122. Her urine PCR improved to 0.03. So 2 years later after dialysis, she actually recovered. And you can see her skin changes seem to have improved as well. She's able to extend her elbows as well. So she had a good outcome. Okay, thank you. That's my part.
I think you need to do your thing. Good morning, everyone. So I thought we'd have an approach to an early diagnosis of systemic sclerosis. To be honest, I haven't seen that many patients with scleroderma renal crisis. And I suspect it's because when they end up going to the nephrologist, going on to dialysis, the diagnosis may be missed. And I think that I've only maybe seen 3 cases of successful treatment for scleroderma renal crisis, this being one, and there were 2 at Barra when I was a medical officer and registrar. So that's the approach to our talk today. And I think everyone knows the definition of systemic sclerosis. It's a rare, it's chronic, and it's got a very complex pathogenesis. I remember as a registrar studying the pathogenesis section in Harrison's, and it was 6 pages and I understood nothing. It's a very heterogeneous disease in terms of clinical manifestations, and it can be quite a devastating disease for patients. So we divide scleroderma into localized and systemic. And often there's this confusion with localized and limited. But just remember that localized has no organ involvement and systemic involves organs beyond the skin. So this was a nice slide just to discuss the spectrum of sclerosing skin disorders, of which you see here scleroderma, localized scleroderma. And I thought this was interesting because I didn't actually realize that lichen sclerosis form fell under this umbrella. So it was described a long time ago by Hippocrates, and I thought this case here by Curzio in Italy was very interesting because he described a patient getting warm milk, vapor rubs, bleeding, and small doses of quicksilver. So I just wonder, is that maybe something we can look at for treatment? Because I know gold worked very well for rheumatoid arthritis. This is the same Osler as Osler's notes, and he described scleroderma patients who died from complications of nephritis. So the current classification that we use in terms of clinical classification is still limited cutaneous scleroderma, diffuse scleroderma, and scleroderma cyni scleroderma, which means they've got most of the organ involvement, but very limited skin involvement. So I thought today should be a discussion on how to recognize systemic sclerosis, because we would often see these end-stage scleroderma patients coming to clinic because the diagnosis had been missed, the symptoms had been there for a long time, but patients got to us by the time they had organ involvement. In rheumatology, it's very important to differentiate between diagnostic and classification criteria, because classification criteria is really a system that is designed to select patients for clinical trials, whereas diagnostic criteria is there to make the diagnosis of a specific disease. Classification criteria is often very, very selective, and you'll find that there's fewer features so that you only select the patients who really have the disease. I think most registrars will remember this. If you've come through rheumatology, you would have seen this graph that we draw. And just showing you that in diffuse disease, you get this very early and rapid onset of skin thickening and organ involvement. Whereas with diffuse disease, you'll sometimes have Raynaud's right at the beginning and a slow progression of skin involvement. And much later do you get the GIT and lung involvement. The problem is that we often pick patients up at this point, whereas we should be identifying early scleroderma. And if you institute therapy at this point, you can ideally decrease the burden of disease for that patient. So there was this study called VDOS, which stands for very early diagnosis of systemic sclerosis, which is different to early scleroderma. Now, early scleroderma means patients have already got the diagnosis. VDOS is a clinical suspicion and then specific criteria where you are looking for the possibility of these patients developing systemic sclerosis. So it was a prospective validated USTAR multi-center study. It was mostly Europe, North and South America. And I don't think there were any African countries who contributed to this when I was reading in the write-up. So what they did was they followed just over 1,000 patients with Raynaud's, right? Now you can imagine in Europe, North America, it's cold, you have really cold winters. So there's a lot of patients who present with Raynaud's. And the patients with Raynaud's who would then go on to meet the criteria would have specific autoantibodies, features on capillaroscopy, which we'll discuss now, puffy fingers, and a positive anti-nuclear antibody. So what was interesting here is out of those 1,150 patients, I think there were 350 patients who already had scleroderma, so they were excluded. And then there were 553 patients who were followed up. And of these 553 patients, remember, these are patients who don't have scleroderma, but VDOS, right? 52% progressed to developing full-on scleroderma. What we do know is of those 53% of patients, if you had a positive ANA, a specific scleroderma autoantibody, and puffy fingers, you went on to progress in about 94% of those patients. If you only had a positive ANA, specific antibodies, and capillaroscopic abnormalities, you progressed in 82% of those patients. So I wanted to discuss all these criteria of VDOS. And I think everyone knows what Raynaud's is. It's reversible vasospasm if it's primary. And secondary means there is an associated disease. So you would typically get the white phase, the blue phase, and the hyperemic phase, right? We often miss this stage of scleroderma. Patients present with puffy fingers, they end up going to local clinics and general practitioners, and lo and behold, you have an arthritis and you get some steroids and anti-inflammatories, and off you go on your way. Sclerodactyly refers to skin thickening around this area, right? It extends from the MCPs up to the PIP, and the skin is quite thickened and very dry and can cause contractures of the hands. So nail fold capillaroscopy, there are textbooks being written on this at the moment. I think there's about 7 or 8 published textbooks. And to be honest, every rheumatologist should be walking around with some form of a capillaroscopic device. This is something that we have in our department. It's a USB. You connect it to your computer. There are ones that you can attach to your phone. And it sits on the nail bed. And you can actually view the capillaries with this in the cuticle. So I was telling my registrars yesterday about the poor man's capillaroscopy, which was described in this textbook in 2015. And lo and behold, do any of our registrars carry ophthalmoscopes? No. So I couldn't demonstrate this yesterday. But basically what happens is you need an ophthalmoscope which you put onto the highest diameter of magnification, which is about 40, just simple KY jelly. And then you learn the technique, which I honestly learned from Prof Tickley as a medical officer, and have used this more often than actually using that machine over there. So there are different techniques that can be used. The USB microscope, which I just showed you here, wide field microscopy, a handheld machine, which is a video microscopy. We actually have one in the department. It costs up to R1 million. There's this Manchester system over here, and then a lot of other things with high-speed video data. So when you look at the capillaries with using a USB microscope, you'll notice that in primary Raynaud's, this is what you should normally see. So you'll see a slightly thickened afferent and a thin efferent vessel. You're looking only at the top level of capillaries. There's about 5 layers, and this would be the most distal of those layers. And we look for scleroderma patterns. So what does this mean? This is just a study group that has decided on what exactly involves abnormal patterns. But what you're looking for is this early scleroderma pattern where you're getting thickening of the blood vessels here. We actually measure that diameter of the blood vessels, right? Later on, you'll see you've got hemorrhaging and abnormal shapes of these blood vessels. They should normally be like a hairpin. And later on, you'll see in the late scleroderma pattern where there's fallout and very few blood vessels left in that distal layer of capillaries. So as I've said, we talk about the early pattern, the active pattern with giant capillaries and hemorrhages, and the late pattern. There are newer technologies coming around with thermography. This is not just designed to look at the capillaries, but also to decide on how much of blood flow there is to the skin, and maybe to aid the diagnosis of actual skin thickening, where sometimes it is quite difficult to decide. Laser Doppler methods. This is quite interesting. The videos on this are quite impressive. And then there are some other emerging technologies as well. So in systemic lupus, we also see some changes. They are a lot more non-specific. They are very related to active skin and renal involvement. You do see some microhemorrhages, and an abnormal distribution of capillaries as well. To be honest, I find that nail fold capillaroscopy is the most useful in patients with dermato and polymyositis. This is a patient from clinic, and you can see the cuticular overgrowth and the microhemorrhages in her cuticle. You can also see the gotrons. And this is another patient from clinic as well. You can see the microhemorrhages, but you can appreciate in this slide here, where you can visibly see the capillaries. By the way, this was taken with an iPhone. Just mentioning. So not a fancy camera at all. We look at autoantibodies, and you'll know that not every single patient with scleroderma needs to have a positive anti-nuclear antibody. We were discussing this yesterday, and in fact, I've seen a few patients who've come to us in clinic and in private practice where a skin biopsy was done to decide on this diagnosis, all right? If you're A negative, you're normally more likely to be male, and it's associated with less gastrointestinal involvement. Everybody knows the different type of antibodies that we look for. The anti-topoisomerase or anti-Scler70, which is associated with progressive interstitial lung disease and renal involvement. Your anti-centromere antibody, which is more associated with the limited type, associated with pulmonary arterial hypertension, but also with significant gut involvement, right? Your U3-RNP antibody, which is not your normal RNP, but a very specific subtype of RNP. And this is associated with pulmonary arterial hypertension, inflammatory myositis, and cardiac involvement. We've got the MTPM-SCL antibody, which we see in the limited, and the anti-U1-RNP, which we also see in the limited. Just so you know, this is not cast in stone, and we see antibodies across the board in all types of patients. And it doesn't mean that if you have an anti-Scleroderma antibody, you definitely have diffuse disease. In fact, you'll see a lot of patients, I think up to about 30% of patients, where you'll have an anti-centromere antibody, but they will have diffuse disease. So the antibody doesn't signify the type of scleroderma that you have. This is just an interesting slide on all the different types of autoantibodies and what they look like under the microscope, right? That's your anti-centromere antibody. You can see it's the speckled appearance. That was the anti-RNP, and this is your anti-JAH1 antibody. I thought that was quite an interesting looking character. And definitely not difficult to, difficult to see, right? There are other pathogenic autoantibodies that we see in systemic sclerosis, but I'm not going to go through all of these today. So how do we classify patients having systemic sclerosis? Now, remember, this is not VDOS. This is proper scleroderma, all right? In 2013, the classification criteria changed, and we now look at skin thickening of the fingers extending proximal to the MCP joints, okay? So it's not just skin thickening of the fingers, it has to extend beyond your MCP joints. If you don't have that, then you look at these 7 items. Skin thickening of the fingers, like sclerodactyly, your fingertip lesions, telangiectasia, abnormal nail fold capillaries, whether a patient has lung involvement or pulmonary arterial hypertension, do they have Raynaud's, and do they have autoantibodies? And you know, in rheumatology, we like giving numbers to everything. So we allocate a scoring system to this. If you have skin thickening, you score 9 points. And how many points do you need to make the diagnosis? 9. You don't need any of the other criteria then to make the diagnosis. If you have thickening of just the skin on the fingers, if it's puffy, you get 2 points. If it's thickened and tight, you get 4 points. If you have fingertip ulcers, you have 2 points. And if there's scarring of those fingertips, you get 3 points. If you have telangiectasia, and the telangiectasia can be anywhere on the body, most of the time you'd see it around the mouth, in the mouth, around the chest, and on the arms, you get 2 points. Abnormal capillaries, 2 points. Surprisingly, having interstitial lung disease or pulmonary arterial hypertension only gave you 2 points. Raynaud's, 3 points. And if you had autoantibodies, specific autoantibodies like anti-centromere, anti-topoisomerase, and anti-RNA polymerase, you got 3 points. The easiest way to remember this is just download the Rheuma Helper app and click on the features that the patient has. So this is something you would only really learn when you come through rheumatology, where we teach you how to feel for skin thickening. And it's a standardized technique called the modified Rodnan skin score, all right? It's normally used for clinical trial purposes. And I mean, I was in rheumatology for 15 years and I thought I knew how to do this very well until we took on a clinical trial and I had to go for training. And it is very difficult, very different to what we were taught initially. So So there are different ways of assessing for skin thickening. There's this method where you pinch the skin up, you're trying to fold the skin, you're feeling for thickening, but you're feeling for texture as well. So it doesn't mean that if skin is tight and bound down, that qualifies as 3. You qualify as 3 when the skin is actually thick and almost like an edematous powder orange feel. This is the skin scoring system that we use. Fingertip lesions. Now, these can be really, really minute and small. I'm not sure if this shows up too clearly, but if you can see these really, really small ischemic pits in a patient who's got a lot of Raynaud's. And then this is often what we would see later on, where it becomes, the ischemic pit becomes hardened. You can get gangrenous, this gangrene type picture here, full on wet gangrene. And some of our patients who develop dry gangrene, and we actually leave these patients to auto-amputate. Fortunately, now we're able to access sildenafil, so we're seeing less and less of this in this day and age in patients in clinic. This is telangiectasia, and you all know that in a patient with limited scleroderma, it can be associated with GAVE or watermelon stomach and be associated with a lot of bleeding. We've discussed capillaroscopy. And just remember that in patients with scleroderma, you get other rashes like calcinosis, tethering of the skin, ulcers over the skin, and the classic salt and pepper rash, which is caused due to depigmentation. I am not going to discuss the other organ involvement of systemic sclerosis. Just remember, you can get renal disease, you can get pulmonary arterial hypertension, interstitial lung disease, cardiac disease, which I think we often miss, the GI tract, which is actually a leading cause of morbidity for these patients, and a lot of vascular manifestations. And this is for my registrars, because we were talking about the pathogenesis yesterday. And there's this assumption that it's only T-cell driven, whereas actually it is both T-cell and B-cell driven, which is why in some of our patients, they respond to B-cell therapy with rituximab. It starts off where something stimulates the fibroblast, right? And that turns into a myofibroblast, which then lays down excess collagen in the extracellular matrix and then causes fibrosis. This is a really long, complex slide, but what I wanted to bring to your attention is we think it starts off here with endothelial cell activation. It stimulates your T cell, stimulates your B cell. Your myofibroblast is involved. You get extra collagen, and then you get microvascular remodeling, skin fibrosis, and pulmonary fibrosis, and the same pathogenesis occurs in the gastrointestinal tract. I'm not going to discuss that. Just to remember, there are many different etiologies of scleroderma. One of them that we sometimes see is, well, we always see is patients who use silica. And this is used in patients who are mine workers, where they're trying to extract the metal from the ore. Patients who are using organic solvents. In fact, we've had 2 patients who come to clinic, and they were both petrol attendants. Okay. Epoxy resin. All of you who are going for all those hobby courses and using epoxy, just be very careful. Use gloves. Okay. Pesticides and some drugs as well. Bleomycin is quite a common drug, and carbidopa as well. Oh, cocaine. I didn't even see that. Okay. Not that any of us use it. Right. So in terms of the scleroderma mimics, this is for the registrars, because you will see quite a bit of patients with thick skin, and not every thick-skinned patient has systemic sclerosis. Scleroderma. This is patients who have this thickened, indurated skin on the back. Patients with scleroderma rarely have involvement of the back. They'll have skin involvement everywhere else, but never really on the back, all right? It's associated with Waldenstrom's macroglobulinemia, cholangitis, hyperparathyroidism. I'm not so sure about that. I don't really see it much in these conditions. HIV, and in some patients with malignancy. You've seen quite a few patients with eosinophilic fasciitis. You'll see this is the groove that we look for, all right? Because that is inflammation of the fascia. And it's got this orange peel appearance as well. Poem syndrome, associated with Castleman's disease. I think you guys probably may see more of this nephrogenic systemic fibrosis. So in patients who've had gadolinium contrast for some reason or the other, who then go on to develop this fibrosis of their skin. Chronic graft versus host disease. I'm sure the nephrologists and other specialists see a lot of this. It's quite common. It occurs in about 60 to 80% of long-term survivors. And what you get is this localized progressive thickening of the skin, often the spodo orange and a groove sign as well, and some skin ulcerations as well. Diabetic chiroarthropathy, we see quite a few of these in our patients in rheumatology clinic who have diabetes, but actually have other conditions like rheumatoid or scleroderma. And you'll find that they have what we call the early, the positive prayer sign. Just to reiterate, there are a lot of drugs which may induce scleroderma-like skin conditions. And I think we leave treatment for another day because that is quite a complex discussion.